talked about autologous transplant for patients who have newly diagnosed multiple myeloma. And essentially, I still think the best therapy for them frontline is to receive induction therapy, somewhere between 3 and 6 cycles of induction triplet-based therapy, followed by an autologous transplant. There's some limitations to transplant, and that is age. Patients older than age 75 are very rarely transplant candidates. Between 70 and 75, some patients are transplant candidates, especially if they're very fit. And I'd say almost all patients less than age 70 are transplant candidates. Most of the people, if they're not candidates for transplant, it's because they have either ongoing pulmonary comorbidities or cardiac comorbidities. But in general, most patients can tolerate transplant. Now, we've done a number of randomized trials in the frontline setting, at least 4, where patients are randomized to upfront autologous, single autologous transplant versus standard novel drug-based triplet chemotherapy. And essentially in every one of the trials, we see that the progression-free survival in the depth of remission is better if you receive an autologous transplant than if you receive the non-transplant containing arm. Now, many of those trials have looked at doing delayed transplant, so salvage transplant when the disease recurs. Unfortunately, most people, when it recurs, don't go on to receive autologous transplant. We really don't have a lot of data in the novel era that would suggest that that's a better strategy to do delayed transplant. So for me, I do frontline transplant for almost all patients.